Tout d'abord, merci aux...
Let me begin by thanking the organizers for inviting me. Now, this is not going to be easy, because I'm coming after Carol, who's explained everything she's told you about fatigue related to cancer and everything. And then I have to leave some time for speakers who will talk about physical activity and fatigue and anemia. So I guess I'll have to talk about just treatment. Share something interesting with you. Maybe talk about clinical research, because Carol was very down to earth, which is also very important, for us on our everyday work. Now, if fatigue is your issue, which is what we are here to talk about apart from just cancer, I shall concentrate on fatigue during treatment and why patients are still tired. Now, there is no universal definition, as Carol said, and we must understand that this fatigue is related to cancer and also to the treatment for cancer. There's several reasons for fatigue. I'm not going to go over them all over again, particularly related to cancer itself. Apart from that, there are certain physical functions which will be induced by this cancer and its treatment, and also what we didn't talk about, when a patient has cancer, he has unfortunately already certain antecedents, and so there are certain comorbidities which we don't really consider enough, and maybe if we did, we would readjust the treatment, and that would help us to reduce fatigue levels. So that has to be considered immediately, and that might be also the right time also to clean up some of these prescriptions, because when you start managing a patient with cancer, it's one way of not overdosing him or her with medicines. You see the effects of beta blockers, etc., which cause fatigue. Now, this is a multiple mechanism, and that's why it is extremely complex to undertake its management. Now, there are several factors, factors, for instance, age, demographic factors, that is, age, family, etc., and then all medical and physical factors, plus all that's biological. So this fatigue doesn't come by itself. Very often this mechanism behind fatigue is also present with the depressive syndrome. Now, what leads to what? Is what came first, the hen or the egg? Plus there's this insomnia problem. It's a vicious circle. I feel that when you start looking at fatigue, one must also consider depression and sleep. In the clinic sometimes, I often forget to ask about sleep and about the quality of sleep, and actually I shouldn't, because it's all very related, closely related. Now, regarding the impact of treatment, fatigue treatment, a lot of progress was made, particularly in understanding the mechanism. Now, if you'd allow me, let me just dwell on inflammation. Now, we know that inflammation is at the very heart of this fatigue that comes especially from cytokines. Now, if you look at what's been said in literature, treatment itself leads to inflammation. So if you reduce the immunity, and particularly the immune environment, be it through radiotherapy, chemotherapy. In fact, there are certain inflammation markers which arise, like the TNF-alpha, IL-6, and IL-10. After treatment too, it's interesting to note, and especially new studies which have showed us that the immune system takes a while to get back into swing. And patients who still felt persistent fatigue showed rates of cytokines which were extremely high. Recent genomic studies also show that there's an increase in genes that code these pro-inflammatory factors, which are then degraded, and that's why there is persistent fatigue. Also, another study shows us that there is a deterioration and an increase persistent and increased cell immunity and reactivation of latent virus, for example, VMC. So that would be interesting to see if there isn't some sort of mononucleosis which has been induced because of suppression due to these therapies, particularly when you look at mTOR inhibitors which reduce immunity, that sort of treatment. Now, Carol spoke to us about the neuroendocrine damage, which is also upset by the cancer treatment. Let me skip that for the time being. Now, what is the impact of treatment as such? To what extent does radiotherapy lead to fatigue, and what have we tried to do? How about hormonotherapy? Does that also do something? Chemotherapy, and then I shall talk to you also about targeted therapies. Do they all lead to fatigue? And which ones should we monitor more closely? Now, as far as radiotherapy is concerned, here in prostate cancer, as we know, because several studies and meta-analyses were carried out which show us that men who've undergone radiotherapy have nearly a 40% increase in fatigue, and particularly if it is combined with hormone therapy. More generally speaking, there were several studies that used fatigue questionnaires, and radiotherapy systematically leads to or induces fatigue. So during radiotherapy, if a patient says he's tired, one needs to believe him because you tend to say it's just local. He is expressing himself. What is the real cause? It's often mixed, but during radiotherapy, since it leads to all this sort of immune problem, leads to fatigue. A few years ago, another study was carried out with 300 women who had breast cancer and followed radiotherapy, also CT and RT. And you see, this was very interesting, that a year later, year after treatment, there were still 40% of the women who felt severe fatigue. And that was due to, they said, radiotherapy. So there was an increase in fatigue during radiotherapy, and which continued for 40% of women post-treatment. Now, regarding chemotherapy, if you look at all the studies again, leads to fatigue, as you might understand, since it impacts all mechanisms: anemia, vomiting, sleep disorder, plus the fact that the patient tends to be thrown by the changed physical appearance. Now, targeted therapies, this is something brand new. And it's a big problem for us oncologists, because this is particularly the TKI anti-angiogenics, and also the thiolene clinase, which is a molecule. All these molecules, if they are taken, lead to fatigue, induce fatigue. And I would say that this fatigue is very different compared to what we've seen with chemotherapy and radiotherapy. So when you talk to these patients, more than 40% of patients complain that one of the major symptoms is fatigue. And some of those who had undergone chemotherapy first and who have now undergone this anti-angiogenic targeted therapy, they feel that chemotherapy was nothing compared to what I'm feeling now with this sort of therapy, because it's all the time present. There's no break with chemotherapy as you have during the chemotherapy regime. And a lot of patients say that they want to stop the treatment completely, because not just of the diarrhea, but the fatigue, which leads to a sort of lethargy and which makes daily life totally abnormal. Now, with targeted therapy, you feel, hey, great, this is less toxic than chemotherapy. But let's not lose sight of the fact that on a daily basis, and it's very important that you consider this factor, fatigue factor, because these patients are popping pills, right? This is particularly true for the old generation of angiogenics, anti-angiogenics, the TOR inhibitors or the GFR inhibitors.
We've just completed a study that we've just submitted for publication. We followed up on a cohort of patients with metastatic renal cancer. And they felt real fatigue. And we wanted to find out if it was for real, because if we look at pivotal studies, there's data, but it's not that clear. So we tried to follow up on that fatigue for patients on anti-angiogenic, and we saw that 90% of patients did develop a fatigue that they deemed to be severe under anti-angiogenic. And when we asked them what was the side effect that was most problematic for you, well, they always say fatigue. So how can we care for this? Well, we have to try in the course of the treatment to find situations, same as what Carol said, that can be either, information, education, or drugs. And indeed, as you said, when we look at all the studies on drugs interactions, there have been a lot of attempts up until now, but few results. We keep on adding drugs, we keep on creating new side effects, and there is for now no guidelines to actually clear that out, which doesn't mean that we have to stop looking for more certainties. Well, non-drug actions, of course, as you said, amongst them behavioral techniques and also physical exercise. If we look at the non-drug interactions, you can see that the literature is getting richer and richer. So all these cognitive therapies, acupuncture, and others, but mixed results. It's never really clear cut, and there's a whole methodological strategy that is always comes into play. So there's probably a necessity to make the statistical criteria more homogeneous when we come to analyze fatigue. When you look at other studies, it's difficult to compare them because the questionnaires are different. There's a whole series of questionnaires, and objectives that are set are not the same. Well, if you look at physical activity in the course of the chemotherapy treatment, we know that whilst on chemotherapy as well as after treatment, well, physical activity, when it is appropriate, can help patients with fatigue. Now, regarding hormonotherapy, does physical exercise help patients with prostate cancer that are on hormonotherapy? The answer is yes. There is a meta-analysis that has just been published that demonstrates that physical activity for patients on hormonotherapy helps with fatigue, plus it gives them more muscle strength and enhances their cardiorespiratory capacity. If we look at fatigue whilst on anti-angiogenic treatment, together with a number of groups for supportive care and associations, we have an objective, which is to set up a physical exercise program that would be appropriate and that would be combined to an optimized nutritional support, so as to improve, so as to help with fatigue in these patients on that are still on treatment, and we hope that we can also increase the rate of survival without disease progression. So this is how it's going to go. There will be a standardized physical exercise program combined with a nutritional program that will be coordinated by Samia Antoun and we from the IGR, and we will reassess every 3 months to try and determine whether it's helped with fatigue, because we know that fatigue is particularly pregnant the first 3 months, and then once it's installed, it's hard to really do something about it. Another option that you may have read about, hypnosis. There is a randomized trial that has just been published demonstrating you look at the blue curve, that when you combine hypnosis or a behavioral technique with radiotherapy, helps with fatigue whilst on treatment. But what is also important is to help with fatigue not only during treatment but after treatment, and it seems to work in the long term. Another approach that we are currently testing, we've actually completed our test, and I think we'll be able to present to the next ASCO symposium in 2016, following the observations that we made that 40% of women after radiotherapy still felt a lot of fatigue, even months afterwards. With the National League, we looked into art therapy, and we tried to figure out whether it helped with fatigue during treatment, whether it helped these women feel less fatigue at the end of the treatment, but also take back ownership of their own body and feel better about themselves. So I got very positive, actually really enthusiastic feedback from these women. We're waiting for more precise data. So to conclude, all treatment can induce fatigue. We now have a better understanding of the mechanisms. I think it is important within the scientific community to go on actively researching new ways of disease management and of caring for fatigue when it is induced by cancer treatment. And it's the same as when we have studies where we try to assess survival without progression. We should do the same for fatigue. And I thank you for your attention.